Good afternoon. My name is Angela Franco. I'm the president and CEO of the DC Chamber of Commerce. It is a pleasure to be with you today as we kick off our annual Health Policy Forum. The DC Chamber's mission is to be the voice of business community in the district and an influential partner to government and local leaders. Our membership comprises of 1,100 companies, including 20% corporations, 20% mid-sized private sector and professional services, and 60% small and local businesses, 40% of which are minority-owned. As the business community's voice, we advocate on their behalf, specifically on policies that could hinder the way they all do business and impact their economic vitality and overall success. One of the ways we support our members and the greater business community is through health and wellness initiatives. In the past, the Chamber released the DC Works Well report, which outlined the outcomes of an assessment of DC small, medium, and large businesses and how well they are providing employee resources to promote overall health and wellness. The report was developed as part of the DC Chamber's work on the DC Works Well grant with DC Health. Through the DC Works Well initiative, the DC Chamber has sought to enhance overall employee well-being by helping local businesses provide the infrastructure to create worksite wellness from the top. For years, we have also partnered with the DC Health Benefit Exchange Authority to help small businesses in the District of Columbia enroll and have access to quality health insurance through the district's ACA Marketplace Exchange, DC HealthLink. Through DC HealthLink, DC-based small businesses with from 1 to 50 full-time equivalent employees will be able to find affordable health insurance plans and prices that best meet their needs and budgets through different major health insurance companies. These are just some few examples of how we support our members and the DC business community in the health industry. On that note, I want to introduce Ricardo Johnson, Executive Vice President for Strategy and Emerging Businesses at CareFirst Blue Cross Blue Shield. Ricardo leads a dynamic team that creates, partners with, and invests in companies that improve healthcare quality, accessibility, affordability, and equity, all in pursuit of a unified vision for CareFirst's efforts to transform healthcare. It is an honor to have you all here, and I really thank all the speakers that are with us today, Councilmember Henderson, Director Kaufman, all our sponsors. Thank you so much for joining us. And please enjoy and learn a lot from the experts in today's Health Policy Forum. Thank you very much.
Good afternoon, everyone. My name is Ricardo Johnson, and I am proud to serve as Executive Vice President for Strategy and Emerging Business at CareFirst Blue Cross Blue Shield. On behalf of CareFirst and my colleague, Sean McDonald, we are honored to be a presenting sponsor of this year's Health Policy Forum. It's incredible to support an event that brings together so many leaders from across DC, some longtime partners, some all dedicated to making our region better and more equitable for all. CareFirst has been a longstanding supporter of the DC Chamber of Commerce for more than 2 decades, and our organization has served on the board of directors since 2007. We are incredibly proud to support the Chamber's work, especially regarding health policy. It's exciting to see that this is our 10th year presenting the Health Policy Forum alongside the DC Chamber. Events like this highlight important initiatives happening to advance accessible, affordable, and equitable healthcare, something that touches the lives of every single person watching this event, something that touches the lives of every single person in our community. So why does health policy and technology matter to the people not directly involved in the healthcare industry? Because these are the foundations for creating a system that plays a critical role in how we access care. And because we know that health inequities are a result and an indicator of much broader inequities in the community. The data are abundantly clear that individual and community health are directly impacted by social, economic, and environmental factors, or social drivers of health, that we can't always solve within a clinical setting. For example, did you know that the life expectancy at birth for someone born in DC varies by 21 years across DC's 51 statistical neighborhoods? That's because of a variety of factors: education, income, access to safe housing, and more, according to the DC Health Equity Summit 2021 report. Technology in healthcare is essential. It's an essential factor to reducing barriers. New innovations are found daily with the single mission of connecting people with the care and resources they need to reduce the life expectancy gap. And if we're going to use technology, we must bridge the digital equity divide, which will be an increasing driver to the results in health equity. The division I lead at CareFirst encompasses an organization called HealthWorks, which is CareFirst innovation and investment arm, which strategically invests in health tech companies in the early to late seed stages and in the Series B plus. These companies are creating sustainable solutions that will propel CareFirst and the healthcare industry at large into the future of healthcare delivery. As the needs of our members are continuously evolving, this is a requirement to the work that we do. The HealthWorks team continues to build bridges between the healthcare delivery space, technology, and the venture capital worlds, and breaks down the walls that have been created between these worlds to add light to what is a pretty opaque system sometimes. We accomplish this in a few ways. Our core portfolio at HealthWorks invests in a number of companies that use digital technology to improve health outcomes. One of our portfolio companies, a DC headquartered company that you will hear from later today, is Socially Determined. They quantify social risk to better target and support CareFirst members and communities throughout their health service interventions. As we build companies as well. And as we build them, we work with countless teams across our organization to develop and refine informed decisions on virtual primary care. Specifically, we started a company called CloseNet, which is a virtual primary care practice that delivers high quality primary care and behavioral health services integrated into one platform, entirely designed around patients' needs, not just their care delivery needs, but also just navigating through the healthcare system, which can be an incredible journey, complicated journey for our members and for patients overall. And through our accelerator, 1501 Health, we provide resources and mentorship to startup companies looking to break into the industry and solve some of our toughest challenges. One example, as I mentioned digital equity before, is a company from our second cohort in 1501 Health, CanDo Tech. CanDo closes gaps in digital literacy, ensuring that people of all ages and backgrounds can access emerging telehealth resources. This is an excellent example of our teams acting as future tellers. The Center for Medicare and Medicaid Services, CMS, recently announced that they consider digital health literacy to be a social determinant of health. And so with our work with CanDo Tech, we've already started the process of ensuring that our members have the skill sets and the knowledge to use the tools that we will provide to them or that others are providing to them in order to increase their ability to drive their own care. But inequity in healthcare and digital health isn't just about the investments. To create these well-informed partnerships, the teams must represent the communities we seek to serve. We say that at CareFirst generally in our employee population, but we know it particularly when it comes to the startup space and the healthcare startup space particularly. We know that 90% of venture capital investment go to men. We know that only 2% go to Latinx entrepreneurs, 1% or less to African American entrepreneurs. This is not only a problem from an economic equity perspective, but from an innovation and thought perspective. If 30% of the country is getting funding for 70% of the ideas, we know that not only is there cash being left on the table, but real investments that go to people, to diverse populations, because we also know that diverse entrepreneurs are more likely to produce solutions for a diverse community. I'm proud to say that our HealthWorks venture team is 71% diverse, which allows us to reduce bias in making investments, enables us to invest in diverse founders and diverse companies as a matter of doing business day to day and not a special endeavor. Of all the cohort companies that have gone through 1501 Health, 85% have diverse founders. Not all of these individuals started out in healthcare. Many started with the desire to make lasting change based on personal experiences. You don't need to be a healthcare company to care about the health and wellness of your communities, your families, your employees. There is no limit to the things outside of a clinical setting that impact health. And luckily, there are just as many innovators out there finding unique solutions to create lasting impact. I challenge you to get out there and talk to some in your community. You just may discover a simple solution already out there that makes your life much easier and your community's lives much easier. Thank you so much to the DC Chamber and the leadership of Angela Franco, President and CEO, and Tanya Kinlow, Board Chair. Hey, Tanya, used to be my colleague. None of this work could be possible without your tireless work and dedication to having these essential conversations with business leaders in our shared community. It truly does take a village, but anything is possible with the combined efforts of the many. Thank you again, and have a great event.
Thank you. Thank you very much, Ricardo. That was great. And thank you, Angela Franco, for your leadership, ensuring that health coverage and equity continue to be a priority area for the DC Chamber of Commerce. At DC HealthLink, we are proud of our partnership with the DC Chamber of Commerce. And together, we have expanded access to affordable health insurance for small businesses and sole proprietors here in DC. And DC ranks #2 in the nation for the lowest uninsured rate, with more than 96% of our population having health coverage. And as you know, for the last several years, DC HealthLink has focused on social justice and health equity. We've changed our standard plan benefit design to equity-based benefit design. This year, type 2 diabetes, which disproportionately impacts communities of color, is covered at no cost to patients. And that includes insulin and supplies, lab work, eye and foot exams, and many other services that type 2 diabetes patients need. And starting next year, we've lowered co-payments for pediatric mental health to $5. Health disparities is a complex area. And to get to health equity, we need to address complex, institutionalized, systemic racism and discrimination. And I'm so glad Ricardo mentioned how complex this systemic discrimination is. He talked about capital investment as one example of how systemic racism works that leads to health disparities. And I appreciate everything CareFirst Blue Cross Blue Shield is doing to look at this area, a very complex area, and find solutions that help to get us to health equity. So today, a panel of experts will discuss how technology and other strategies can be used to get to health equity. It is my pleasure to introduce to you today's panel. First, Council Member Christina Henderson, who is the chair of the Committee on Health for the DC Council, and I should note, oversight chair for DC HealthLink. Lauren Hettinger, Vice President, Strategic Solutions, Socially Determined. Dion Norris, President and CEO of iHealth Innovative Solutions. William Sheehan, Vice President and Chief Innovation Officer, MedStar Health, and Executive Director, MedStar Institute for Innovation, and Dr. Anita Arno, Director, Office of Health Equity at DC Health. And last but not least, I would like to introduce and turn the virtual floor over to our moderator, Charlene McDonald, Chief Government Affairs Officer at CareFirst Blue Cross Blue Shield. Charlene leads the company's advocacy, public policy, and government affairs team to engage in policy debates that impact health outcomes. Charlene brings her expertise in policy, strategy, and external affairs to support CareFirst's mission of furthering accessible, affordable, equitable, quality healthcare for people and communities in Maryland, Washington, D.C., and Northern Virginia. Charlene is an active member of the Board of Directors for the National Capital Area chapter of the Alzheimer's Association and volunteers for the Virginia Medical Reserve Corps. She holds a master's in public policy from the Harvard Kennedy School and earned her BA in political science and sociology from Lake Forest College. Charlene, the floor is all yours.
Thank you, Mila. Thank you for the introduction and for the important work that you do at DC HealthLink. I'm so excited to be here today with my colleague Ricardo and with this amazing panel of experts for this interesting topic. So let's go ahead and dive right in because I know we're going to have a lot to talk about this afternoon. So over the past several years and even decades, technology has transformed the healthcare industry in so many ways. For example, looking back at the adoption of electronic health records after the HITECH Act, which has revolutionized the way that medical professionals track patient information and exchange that information. Better alignment of payers and providers and unified medical records can play a critical role in enhancing the quality of care and ensuring data integrity. So for the entire panel, within each of your individual areas, how has technology driven value for consumers, improved health outcomes, and created efficiencies? And I'll start with you, Dion.
Oh, perfect. Thank you. And again, thank you for the invitation to participate on this panel. Obviously, from a consumer standpoint, one of the goals that many agencies and our customers and governments is doing is really providing modern, streamlined, and responsive customer experience. And this is across all platforms within a service delivery. We're also seeing that the improving on digital solutions, having access to health data records and, again, having access to health data records at any prospective time of the day. Also, we're seeing transitions within telehealth, the things coming across. You start to see things from accessibility, reliability, and healthcare insurance. Other things around that piece from a customer perspective is really the integration of platforms and really seeing the benefits from those programs. As we start to see technology evolve, we're starting to see the integration of, different things and from calorie standpoints of what are you eating and how is that trending amongst people around your age, being able to catch different type of, processes within, and be able to innovate the products and solutions to develop those products and services. What we're seeing from a healthcare outcome perspective, really is around data and the intelligence of data. It's really helping prepare agencies and plan for improved strategies of foolproofing operations as they continue to advancing public health, regardless of the emerging challenges. This is things around getting vaccines and, cures faster through the advancing process and supply chains, and also using things such as rapid evolving virtual care models such as precision medicine and VR technology. This is also helping trying to improve or creating improvements around diagnostics using data analytics and intelligence. For example, looking at diabetic retinopathy, it is probably preventative from blindness among American adults, and that's around 80 to 90% preventable through proper diagnostics and treatments. And so what we're seeing is imaging allowing providers to capture those images and send them to board certified eye care providers who then can review them remotely and then provide the ease of confidence of looking at increased diabetic retinal exams as compliance to increase the likelihood for early detections. We're also seeing a vast majority of the things as far as efficiencies around automation, business processes, artificial intelligence, machine learning, and really those things are key to improving quality and controlling costs. Automating appointment scheduling and management when you're going into the physician's offices and things of that nature, being able to book it online or book it through chat or chat GTP. Medical coding and billing automation within healthcare. You are able to build accordingly and catch signs of improper billing through QA and quality control, as well as revenue cycle management. And so those are some of the things that we're starting to see along the lines of trying to create these efficiencies within the healthcare pyramid.
Thank you, Dion. So many areas that we could go with this, but I want to go back to the point that you made on public health and ask Councilmember Henderson to speak a little bit to how the development of health technologies has really transformed things on the public health side from her perspective as a policymaker.
Thanks, Charlene, and thanks to the Chamber for inviting me and for having me. It has helped in lots of ways, I would say, for the resident side. One that immediately comes to mind, as a parent of young kids, we're really excited about, universal health certificates finally being electronic. So we don't have to do the paperwork transfer or the data entry side. And that it's something that lives, as opposed to, when I was little, my mom had to hold on to that yellow card that had all of my shot records. And so I think, technology has definitely helped from an efficiency standpoint. It's also helped in a little bit in terms of what Dion was talking about around even diagnoses, but also being able to track some of the chronic conditions and help folks manage those chronic conditions that they have. Diabetes really being the number one at this point, where you don't even have to prick yourself every day, right? There is technologies that send you an alert, not just to you, but can also send it to your primary care provider or whoever is helping you sort of manage your care to say, hey, we're noticing your levels are a little bit low. And so that keeps someone out of the hospital, that allows for them to be able to sort of take immediate action. So it's definitely helped a lot. And, from the policy side, technology has just increased the amount of data that we have to be able to make some assessments in terms of quality of care, whether that's the data information that we get from our managed care Medicaid MCOs to sort of know how many doctor's visits are folks doing. It just helps us to better understand and to better target our dollars in terms of what's working, what needs more improvement, and where should we double down.
Thank you, Councilmember. And Bill, from the provider perspective, can you speak a little bit to this question on outcomes and efficiency?
Yeah, thank you, and it's a pleasure to be here. Really great discussion from the two prior speakers. But maybe to add a little bit to some of the points that were made, I think telehealth is a great example of a technological tool in healthcare that really saw accelerated adoption during the pandemic. And that's both on the provider side and on the patient side. But I think there's an opportunity to maybe go a step further, and we're spending a lot of time thinking about that rather than just replacing in-person care with video-based care, it seems like there's a lot of opportunity to very deliberately deconstruct the care models in different service lines. Take primary care and kind of access to primary care is a good example of that. To really rethink the model and use tools in addition to video-based care, asynchronous, text messaging, lowering that barrier to entry for diverse populations to asking questions and getting access to care. I think remote monitoring and kind of that patient engagement outside of episodes of care is a really big part of the future, right? Where we can monitor chronic disease monitor care transitions as examples, between acute care and home or facility-based settings, and really ensure those are done safely and staying in good contact with patients during those difficult care transitions or during the management of chronic disease. And generating data that was mentioned, I think, by Dion, both consumer data from all of the devices that we all introduce into our own lives, but also introducing, healthcare grade technologies in the home that are cellularly enabled to increase access to them and the ability to transmit data and allow for those data to inform longitudinal care for patients over time. I also loved the point about access to information and use of information. I think that that's on both sides of the equation, both better access to broad information sets for the care of patients on the provider side, but also for patients to have access to their own information and access to really well, I would say, curated libraries of information to help inform their own care. And that really leads to better shared decision-making and engagement of patients in their own care, which also leads to change and better outcomes in chronic disease burden and longevity. So I think those are some good points. I'll finish by maybe two more that weren't discussed yet. One, which Dion may have mentioned a little bit, is the application of predictive analytics and artificial intelligence in healthcare. I think this has a really big future, but it comes with some asterisks of risk that we need to be really smart about. But I do think that using big data, which there is now so much data in healthcare, and using artificial intelligence and machine learning to help us understand those data and identify patterns in data that historically would take tons of time and money to do clinical trials around different interventions. The truth is the answers are often in the data that already exists, and using those data to help identify those patterns through artificial intelligence is going to be really powerful. And I'll throw another interesting one that I think is both consumer driven, but also now is being healthcare driven, which is virtual and augmented reality as a kind of tool in healthcare. And there's really good data coming out about the use of immersive virtual reality in the treatment of depression and other behavioral health diagnoses. There's also opportunity, I think, to help patients in the navigation of care. Imagine being able to immerse yourself through virtual reality in the operating room before you're wheeled in, so you understand what you're going to feel and see and hear in that kind of environment. And then taking it to the provider side, I think there's really kind of Star Trek-y technology in the near future here, where you could have surgeons wearing augmented reality headsets and actually seeing medical imaging through the skin of the patient to be able to visualize what's going on inside the patient as they're doing minimally invasive surgery, et cetera, to make sure that we're doing those types of procedures really safely. And that technology is on the edge of being clinical ready and going through FDA approval. So I'll stop there, but lots of exciting things in technology. And I think it is driving better outcomes and experience of care for patients and reducing burden on the provider side.
So much potential for change, and you talked quite a bit about data, and I think we can have a whole panel on data alone and the potential there. But I know it's particularly important as so many of us work on trying to reduce the impact of disparities of social determinants on health. So we'd love to hear next from Dr. Arnault on her work with the DC Department of Health Equity.
Yes, thank you so much for having me on this panel. Really appreciate always working with Angela and folks at the Chamber, and to kind of meet many of you who I've met before, or at least have heard of the great work that you're all doing. Here at DC Health, we are laser-like focused on health equity, even beyond my department. So all of the things that we do here at DC Health is viewed through that health equity lens. What I do know is that from a population health perspective, data, which is what Charlene, you talked about, has been critical. In fact, raising the bar and folks' understanding of how critical the non-health care centric things are in the health of district residents has been the kind of focus of my work. And in terms of knowing that 80% of what drives people's health has nothing to do with health care specifically, but it's all the other things that come together to create the context in which we all live, learn, work, play, and age. What we do know, and I think a couple of my colleagues here on the panel have mentioned the pandemic, and I think the pandemic really, if anybody was not paying attention before, underscored how those inequities play out, especially and including technology. And what we saw, two things happen during the pandemic. Number one, most of us lucky enough to go home and stay home and be protected, were able to do that and continue working because of technology. Many folks found that to be a barrier. Kids in particular were left out. We know, for example, one of the things that came up during the mayor's Reopen DC process was that broadband technology was a major gap for kids in particular, but for all folks. Right now, I had my team look at the data. About 25% of households in the district don't have access to high-speed internet. And so as we sit here talking about how great this is and how you can reach patients, it's a barrier for 25%. But what is more, those 25% are not evenly spread across the community. What we see is broadband technology mirrors all the other inequities that we have. So the data shows that something like 25 out of the 51 statistical neighborhoods that was mentioned earlier that we use, something like 24 neighborhoods have more than 25% without access to broadband. Some 9 neighborhoods have 40% of residents without access to broadband, and the actual highest rate is 53%. So that as we talk technology and we talk about the opportunities, we have to also keep it real. And in fact, I found an interesting quote from Karen DeSalvo, who used to be in public health, did some great work in the federal government, but is now the chief health officer at Google. And she said, and I'm going to quote, "In the digital world, we all get excited about innovation and tools, but their excitement is pushing towards the ceiling and everybody is losing sight of the floor." And for me, what that means is that we have to keep it real for 25% of residents in the district, but also for in some neighborhoods where they are seriously challenged. And I think that is how we have to think about it. But we did see also during the pandemic that we were able to fast track telehealth, right? So we can leverage these opportunities when they arise, but we have to make sure that it is equitably accessible for all district residents. And as it becomes the increasing thing of the future, that we really pay attention to this floor part. So that will be my kind of generalized comment on where we stand right now.
Absolutely. And I think, Lauren, at Socially Determined, a lot of the work that you're doing with Care First and other partners is aimed at tackling some of the challenges that Dr. Arnaz spoke about. Could you speak to how technology is playing into your ability to achieve your mission?
Yeah, thanks, Charlene. And again, thank you all for having me. This has already been really interesting and exciting. So as Ricardo described earlier, from a social risk analytics perspective, our focus has really been on leveraging data and technology to assess and quantify social determinants of health and social risk factors across markets and in populations. So I love what Phil said about moving health engagement outside of the healthcare setting, because when we think about a year in an average adult's life, which if you've ever seen Rent, is 525,600 minutes, approximately 90 of those minutes are spent in the healthcare setting receiving healthcare services. That's it. And yet so much of the data available to drive healthcare improvement is limited to the information that's collected in those 90 minutes. So as Dr. Arnaud called out, and we all sort of are familiar with this, 80% of healthcare outcomes are influenced by factors outside of the clinical setting. And social determinants of health and those social risk factors, like whether a person has access to healthy food, transportation, whether they can afford a quality housing, or the digital landscape of their community, a tech-enabled analytic approach allows healthcare stakeholders to, across their populations, understand the relationship between clinical and quality outcomes and social risk. And then they can more quickly and efficiently identify the specific needs and areas of opportunity for intervention. So what is that basement, right? What is the bottom looking like? And so what we've seen is that when we think about that life cycle of connecting a patient or a member with an intervention that can address those health-related social needs, the industry has spent a lot of time focused on that last mile, which is screening a patient or a member and then connecting them with an interventional or referral partner. And it's good. We should be doing that. The process is time consuming, it's resource intensive. It also serves a very specific and important tactical purpose, which is truly understanding a person's immediate point in time needs and the barriers to care so that they can be appropriately addressed in that moment. But it's not a data collection strategy, and it shouldn't be. And that's really where we think that tech-enabled social risk analytics piece is really key. I just want to draw some efficiency parallels really quickly. So the University of Chicago recently published a study that showed that that less than 2% of all Medicaid or Medicare recipients have some sort of SDOH code in their claims record. We know it's more than that, right? And what we've been able to do at Socially Determined in a technology-enabled way with population-level social risk analytics. This last January, we had a customer send us a roster of 2 million of their members across all business lines on a Friday afternoon. By Monday, we sent them a data package with social risk information, things like their individual's food insecurity or housing instability risk on every single one of those members that they could then pull into their enterprise system. So they can analyze it and explore it and think about those connections between outcomes and risk. So when you think about time to value, the efficiencies that can be gained in this space through technology are truly meaningful. And again, I want to just say one-on-one screening or technology-enabled screening, that text message outreach, it's really important. But when we think about making strategic investments and the efficiencies that gain from being able to look across populations, the technology-enabled analytics allows us to get to action much faster. So what used to be a reactive model to addressing health needs can now be proactive in a much more scalable way, which really means for the consumer that healthcare quality and outcomes are better, costs go down, the patient experience improves. And if a consumer has SDOH needs, as someone who consumes healthcare, because we all do, you're more likely to be connected with the resources that would help you meet those needs.
Thanks, Lauren, and thanks to all the panelists for the insights on what technology can do to address so many of the challenges that we face in our healthcare system. I do want to acknowledge the pragmatic considerations, though, and think about what are some of the challenges and opportunities with integrating that technology into existing healthcare systems and processes. And have you identified any best practices for successful integration? Dr. Arnaud, I'll start with you.
Well, I think some of our challenge is in terms of what is successful. I know one of the things we're working on right now is to try to really talk about health literacy in the district. And yes, we are planning to build, well, we're not planning, we've already started building a portal. The challenge, however, is, and I think Lauren talked about this last mile and how do you actually reach folks? We want to improve people's health literacy, which is critical. And technology is part of the solution, but how do you ensure that folks are actually connected to that data? So what we have done, we're building a portal that has 3 different audiences. So that's the concept. And it's gonna look at what patients need, what organizations need to be organizationally health literate, and what healthcare services organizations that most of the folks on here are, and how do you connect those 3? But we have put our focus on thinking about the bridge organizations. So not the healthcare serving organizations, but small nonprofit organizations in neighborhoods that have a closer connection with their communities and cultural competence, et cetera, who can serve as that bridge. And so we at DC Health can't be all places at all times, but we can actually engage and leverage their built-in relationship with communities in their neighborhood. So that's what we're testing. I'm not sure it's the actual solution for everything, but I think it's a part of the solution. What we found during the pandemic is that we have a lot of resources in the city. We have a lot of FQHCs, but it's very difficult to get folks who are, we talked about that before, busy living life in getting on with the business of life. And they may be actually going to a food bank or somewhere else that could be a better trusted messenger on their behalf if they're the ones who are telling them about the portal and those kinds of things. So that's one of the things that we're working on, and going beyond the episodic approach to care, but also having folks keep their own records together. We've developed a nice little booklet that people could use to take to the doctor's office with them. So it's those tools. We're also working with those small CBOs to kind of figure out what works best. So we don't know if if we don't know the answer, so there's a lot of resources developed for healthcare serving organizations, and the healthcare serving organizations on this call have the resources to build the tools for themselves. But for bridge organizations, they need the help of public health, such as myself, but also all of the other folks around the table who can enable that process.
That's a great point, Dr. Arnott. The technology has really transformed how we think about the sites of care in healthcare and sort of going beyond the traditional doctor's office. But of course, that's still an important part of what we do and how we reach patients. Bill, is there anything that you can say about what you and your colleagues at MedStar are doing to integrate these technologies and make sure that you can leverage them for patient benefit?
Yeah, I think I would build off of some of Dr. Arnott's comments and say that I think the issue for technology in the healthcare setting, and I believe it was you that mentioned electronic health records early on. Electronic health records are actually an example of where they have a wonderful purpose, but they've actually had a lot of impact on provider well-being and relationship between providers and patients. We've all experienced, right, the provider, the nurse being focused on the screen and not the patient because of what documentation and EHR burden has done in the healthcare setting. So I think there's a cautionary tale of integration with technology that we have to make sure we're fundamentally remembering that technology should be an enabler, but it is the personal care of that patient and their needs that should be front and center. And maybe along those same lines, I think there's a real disservice that technology innovation can do to healthcare by fragmenting healthcare delivery further than it already is. I think we've all, heard that there were thousands of healthcare technology startups that came out during the pandemic, right? And we see lots of consumer-driven adoption of, personal health and well-being applications. We see lots of non-traditional provider organizations coming into the market, offering services, sometimes in partnership with payers, sometimes direct, cash business. By the way, think about how that's driving disparity in access to healthcare, right? When folks who have resources can spend those discretionary dollars to access, better healthcare now in new digital ways. So I think this fragmentation problem is only going to exponentiate. And we have to be really deliberate and thoughtful in thinking about where is longitudinal connection truly necessary in healthcare for better health outcomes, but leveraging that technology innovation where we can to drive better outcomes at the same time. And that's a really difficult balancing act.
Definitely. Thank you. I want to shift back to the conversation on data and health disparities and inequities, and think a little bit about how we can inform targeted interventions to address those disparities. So CareFirst, as Lauren well knows, has partnered with the team at Socially Determined to provide social risk analysis and support for a multi-year initiative focused on addressing members with diabetes. We use the data to identify that within our commercial plan, members with diabetes who also faced an elevated risk of food insecurity had out-of-pocket healthcare costs over $300,000 higher than similar members who did not face the same social risks. So the cost is very real to our members. Empowered by this information, we were able to design a tailored multi-factor intervention to meet the specific needs of that population. It's a great example of how data can and should be used. But how can we ensure that healthcare organizations ensure data is used in a way that is inclusive of diverse population and doesn't perpetuate existing biases or disparities? And Lauren, I'll go to you for that.
Yeah. Thank you. Charlene, I love that example. It really highlights how important data is to any health equity strategy. If we can't identify disparities, we can't address them. And the challenge, as you've identified, is ensuring that we're using data in a way that is inclusive and doesn't perpetuate those existing biases and disparities. A study out of Northwestern Medicine recently conducted performance reviews of 5 machine learning models used to determine the outcomes of hospitalized patients. And then they integrated measures of SDOH after. And prior to adding SDOH data, the best performing model underdiagnosed several underserved populations, including female, Black, and socioeconomically underserved patients. And then they found that the addition of that SDOH data led to improvement in the fairness of the models. So there's a lot of power in this population level social risk data, like what CareFirst used in our partnership. Having data on the social risks of people and the factors in the community allows us to not only uncover the differences in those outcomes between groups, but also think about identifying the upstream factors that can prevent health equity from being achieved. So in the case of the Care First example, we identified food insecurity and health literacy as a part of what was driving some of those suboptimal outcomes for the diabetic population. We talked about this already, but so many healthcare stakeholders are collecting that social risk data through screening or interactions with the healthcare system. And the challenge, again, it's really time consuming. It only works in certain care settings, and it requires engagement from the individual. Dr. Arno talked about this, but if they're not engaged, it can entrench existing disparities and introduce that additional bias, because those same people who have historically been underserved are likely those that aren't engaging in the ways that ensure they're getting screening. So if we're looking at it as our primary data source, we're just collecting data on the people who've shown up. So it's also important to consider screening has to be appropriate in the right setting. Dr. Arno talked about going to where people are. Historically underserved populations are often the least comfortable sharing personal information. So when they do, stakeholders have to make sure they have a strategy for action. And so that's where we have to be ensuring that we have the right partners and resources to support a population, that we're proactively working to connect people to those interventions and resources, the people with the greatest need to the interventions and resources they're most likely to benefit from. And so this Care First example highlights this ability to sort of cohort or subsegment members of a population that are most in need of intervention in a way where you could prioritize outreach to those populations in a proactive way. I want to just add to, I like the example because it highlights that the health-related social needs are not unique to the Medicare and Medicaid population. It's an obvious statement to anyone who works in the industry, but a lot of work in this space so far and a lot of the incentives that we've seen have been focused on Medicaid and Medicare, which they should be, we should be. But population level data has allowed Care First to think a little bit more outside the box and identify those subpopulations within their commercial population with health-related social needs. And in many cases, those are people who are churning on and off of Medicaid, and they can look similar in terms of their social challenges. And so actually, by identifying pockets of a risk within their commercial population and even within different large employer populations, I've been working with Care First. Actually, they're beginning to partner with some of their larger employer customers around ways they can better tailor benefits and programming to support employers' health equity goals. So now we're not just talking about addressing direct healthcare outcomes, but immediate outcomes like employee retention or sustained employment for the individual. And so to bring it full circle, it gets back to the importance of that population level data so that our strategies or algorithms aren't missing people, and that resources and attention are being appropriately focused on the populations that are historically underserved across all sort of business lines as we think about them in healthcare.
Absolutely, and that certainly important to keep that in mind from a business perspective, and of course also from a policy perspective. So I want to go back to Councilmember Henderson for a moment. Councilwoman, even before your tenure as a member of the DC Council, you championed a variety of issues on behalf of the residents of the district, from maternal health and equity, et cetera. So you and other policymakers are facing unique challenges as you try to balance addressing the complexities of rapidly evolving technologies like the ones we're talking about today with more fundamental issues related to equity and privacy. How can policymakers think about leveraging data to inform that policymaking and create policies and positions that advance health technology while also preserving equity and promoting equity and protecting consumer privacy?
I think you kind of hit sort of right on the nail in terms of needing to both balance the desire to get data-driven outcomes and using data to promote equity and good, but also wanting to protect against data being used to, continue to foster biases against certain populations of individuals, but then also from a data privacy standpoint. As someone who, my husband is in technology field and works in the tech space. So I have a different, I think, view in terms of the data privacy piece. And when I talk to folks, I try to remind them, the companies that know the most about you are like the grocery store that for whom you use, the little rewards. They know how often you're eating produce. They know your dairy intake. They know whether or not you are a frozen food person or, you're going strictly organic. And yet people feel weird about data privacy outside of sort of thinking in that same vein. And so I think for us, it is a balancing act of wanting to make sure that we can get the outcomes and information that we need, wanting to make sure that there is the care coordination and the sharing pieces of that, but also to make sure that it's also not used against people, whether it be from algorithms or this data now being attached to you and getting into the hands of individuals who don't necessarily need it. Lauren was talking a little bit about in terms of employers wanting to improve, their wellness outcomes, et cetera. But for some people, they don't want their employers to know either that they're seeking treatment for something particular or those kinds of things. So while it might help them on their wellness side from a work perspective, we still need to respect the privacy of individuals in order to seek the healthcare that they think is most appropriate to them without thinking that it's going to have repercussions in other sectors or other parts of their life. And so I think for us, it's always this, if money were infinite, we could try everything, but money being finite, I want to make sure that where we are investing, particularly taxpayer dollars, is in an area and an approach that is going to have its most bang for its buck. Obviously willing to try new things, but the data piece is important for us to know whether or not it's actually working. I had an exchange with Director Turnage, who's the director of healthcare finance, about this a couple of weeks ago when we were talking about the amount of money that we spend for Medicaid managed care and versus the care coordination that's actually happening around maternal health. When I look at the data, the fact that I still have upwards of a third of women in the district, Black and brown women in the district, who are not seeking prenatal care until their second, third, or not at all part of their pregnancy, that's a problem, in my opinion, in terms of our ability to get better outcomes on the maternal health side. And so how are we using this data to hold these companies accountable for the work that they're doing? So I think it's a variety of different ways, but from a policymaking standpoint, it's a balance. I think it's also around communicating to the public because, for them, data privacy is like, oh no, I need to hold on to that. Not realizing that literally every day when you go to a Target, right? When you go on Amazon, when you go something on Google, the amount of information that they have about you, and you actually like it because you know why? It serves up the algorithms, it serves up the suggested things so you don't have to continue to look for things. And so not fearing technology as big brother and this big bad thing, but also seeing it as a way to help improve outcomes in your everyday life.
And with all these increasing uses of technology, specifically sensitive health data, Dion, can you talk to us about how innovators and the users of innovative products can promote consumer privacy and protect consumer data?
Yeah, no, that's actually a great segue into that discussion, right? So we look at it from a user perspective. I think the biggest issue is password changes, right? No one wants to change passwords, but if we implement things like multi-factor into your accounts, that creates another barrier for those individuals who are trying to get access to your data. Even educating the user base around privacy and protection, I think we don't spend enough time discussing that internally, having the annual trainings around spam and phishing attacks that can prevent malware and ransomware and things from locking up your system. Also seeking feedback on what works and what doesn't work within, your community and providing an instant access back to some of the stakeholders so they can make the right decisions. Now, from the corporate side and the agency side, there's a couple, obviously, addressing and assessing those critical issues regarding protections of sensitive data, assessments and healthcare checks, right? The health checks, the annual health checks and periodic health checks help to address some of the configuration verifications and the data locations and the tools and validations that go and exist, right? So, you have this collaborations among many agencies and many organizations, and you have data that is spread across everywhere and no one knows where that data lives. And being able to introduce tools and technologies to be able to track and tag that data, that way if you do have any type of breaches or those type of concerns, you're able to track and really address those issues from that perspective. Now, when you're exploring some of these things, you have to implement some of the strategies that will balance the cloud transformation and IT modernizations that we started to see within some of these requirements. And so we work with CISA, the Cybersecurity and Infrastructure Security Agency, around zero trust, which is now going to be a mandate that's going to really help agencies and organizations really go one step forward and to identifying, authentication methods when you are creating an environment that is basically saying no one is going to be allowed onto my network unless they are running this particular tool to authenticate. And even from a second pillar, you're going to also validate that only certain devices are going to be allowed within my environment. And then you get to that network and environment pillar. And that's really around the discussion around locking down instant access and instant control to some of the tools that you once had access and freelance of to now you don't have access to. It's not so much of not providing you the collaboration and into the environment that you need, but more so trying to control the visibility piece of it, and then getting back to the application workload. Every time someone goes in and they any type of development, you have to have those checks and balances around where that development lives. And so we're starting to see where all this data compositories and things of that nature are being automated. It just needs to be some self checks around data that will help address some of those things. And what we're seeing from a cybersecurity standpoint, we're also introducing AI into cybersecurity. And what that does is it helps track trends and things of that nature around your perimeter defenses to really take a step back and say, well, why are we having these IP addresses continually to try to access this particular application at this particular time? Why are this particular data backup or running at this particular time? And then we're having these outsourced things that are trying to capture this particular data. And so it provides a validation as well as the orchestration of where that data lives. And even going one step further, developing the security or cybersecurity workforce, it really talks about the integrative approach that some of the government agencies are starting to do. And it's going to something that has to, as we start to move forward with all the data that are living in the public buckets or data volumes and data sets that are living everywhere, we have to figure out a control mechanism that will allow us to prevent those type of things from happening.
Thank you, Dion. And I want to go back to the role of technology in direct patient care. And Bill, you talked a little bit about the strain on providers from the use of electronic health records and other administrative burdens that providers are facing. Can you talk a little bit about how that's feeding into the shortages that we're seeing in the healthcare workforce and what we can do about it?
Yeah, it's a great question, and certainly it's a part of the challenge, right? I think some of the burnout and resilience issues are related to honestly what's been a pretty difficult care environment for the last few years during the pandemic, but also particularly in the acute care setting, and I think that's where we see the kind of biggest staffing shortages, although it certainly extends beyond the acute care environment also. And so I think it is a big part of it, but there's ways we can use technology to continue to try to address some of this also. And in the acute care setting, as an example, we're spending a lot of time thinking about how to change technology in patient rooms to really enable, like we did in the ambulatory setting with telehealth, virtualization and standardization of certain parts of the care model to really leverage a smaller workforce, potentially because we don't have the nurse staffing, et cetera. Leveraging virtual nursing to extend nursing care across, for obviously things that don't require laying hands on patients, but there's a lot of teaching and education and questions and whatnot that can be handled virtually. I also think that there's really interesting emerging uses of sensors and cameras in patient rooms. There's privacy concerns there, right, that need to be addressed, but advances in computer imaging technology, and they call it computer vision, could actually help us keep an eye on patients who have fall risk, right, in patient rooms, and using kind of edge technology, understand when they're at risk of potentially falling out of bed in the inpatient environment or being unstable on their feet, or imagine being able to identify violence in the care environment, right, by leveraging sound as a data source. And so I think there's some really interesting, violence in the acute care environment is certainly another part of that dimension of workforce shortage, not technology related, but super important to note it. And there may be technology interventions like that can help us address it. I might also go back to say automation is a really important, part of the future in these things. Helping us identify the right patients for fall risk, predictive analytics in that space, or maybe in the ambulatory environment, thinking about, lower bottom of license work for providers, like things that can be really standardized and protocolized, like prescription refills, right? How can we've all had that frustration, right, of it taking 5 days to get a prescription refilled. Really, in most cases, in 70 or 80% of the cases, against a protocol, those prescriptions can be refilled with much less time spent by providers. So inserting automation to kind of in smart ways allow for the humans in the system to practice top of license and spend the most time with the most complex, kind of problems versus all of these tasks that have really built up over time. Some of them are technology related, as we've talked about, and trying to offload that burden through some automation technologies.
And Dr. Arnaud, what are you hearing from clinicians on the role that technology is playing in their day-to-day and how its impact on their ability to deliver patient care?
Well, I actually don't work as much directly with clinicians and on my day-to-day. I do have a daughter who works in emergency medicine. And so I hear from her, oh, I've got to go home and fill out this form. So I hear about the forms and all those kinds of things. But I do think some of what Bill had said earlier, where he talked about us rethinking what a clinical encounter needs to look like, as opposed to just simply trying to take what we currently do into the virtual space. I think that's really where the kind of cutting edge needs to be. I think we need to leverage technology, but we also need to leverage care by individuals to the extent that is possible. I think there are two things that are happening in healthcare, and I think some of what Council Member Henderson talked about. We need to build a culture of health as opposed to a culture of health care. And so to the extent possible, we need to figure out how healthcare becomes part of our total package so that we're not waiting, for example, for women when they're pregnant to start going to the doctor on a regular basis. It just becomes part of their culture of health, because I think that's what we're really fighting against. People are not going to the doctor on a regular. And so when they become pregnant, they're still not going to the doctor on a regular. So we don't really have a kind of baseline of what your health status is. And I think that's really where to me, the biggest gap is, that we have a culture of episodic care that is completely different to what, for example, they do in Japan. In Japan, they go to the doctor multiple times a year, everybody, all through. They live the longest in the world. They go to the doctor more often than we do in the US. And we usually well, I'm not sick, I'm not going to the doctor. So I think it's our model of how we think about care. And especially as we start integrating mental health into health care and physical care, that becomes a much more holistic approach. And for me, that is how we need to expand. It's a lot, I know personally, once you've built a relationship with the provider, it's a lot easier to then chat with them on the phone, send a text message. You can then use all of the methods of communication when you feel comfortable. You know the person's face, you know what they're going to say, you feel a sense of trust because you've gone there multiple times. That to me is really where our biggest gaps are across the board, including for men who don't go to the doctor very often. We only talk about women. But we need to change the culture of the way we access health care as a part of a total continuum of culture of health. So that would be my thought process here.
That's a great point. For any of the panelists, are there other opportunities that we're missing as we seek to transform care delivery through technology?
I would come back to a little side comment I made earlier about being a little terrified about artificial intelligence, but it has so many potential positive applications in addition to having some maybe darker sides that we need to consider. And one of those is actually in documentation of care and communication with patients of what can be conversations that are difficult to remember, especially when you're getting difficult news in healthcare settings. And so, I think there's, the advancements in ambient artificial intelligence and being able to listen and understand context of human dialogue and interaction, I think has a really interesting future for this. I don't think the technology is quite there yet in the healthcare setting, but we've all seen Siri and Alexa and others really advance in the ability to understand, text or move text to speech to text. So I think documentation and communication has an interesting future, with microphones listening, and then documentation and sharing. It could even be audio recordings in the future of care interactions with patients to really help them absorb information multiple times instead of these transactions that where information is lost.
Thank you. And that actually is a great segue to my last question before we get to the Q&A. Just on the future of technology, we know it's played a vital role in transforming healthcare and making it more accessible and efficient and personalized. But as it continues to advance, what are some of the other innovative solutions that you foresee coming into the healthcare system that will change delivery, ideally advance health equity and improve patient outcomes? Dion, can I go to you?
Oh yeah, please. Please, council member.
Well, you guys are the tech experts, so I'll just speak to what I hope to see, perhaps from technology, from a health innovation standpoint. I hope that we can use the technology to advance some areas of research that have not been focused on before in terms of particular diseases or conditions that have impacted particular marginalized groups that we haven't necessarily seen a lot of research on. So thinking about, fibroids, for instance, in terms of how that shows up in women and impacts in other ways. Maybe we can see further advancements in terms of breast cancer. So I'm hoping that technology can be used to crack the code of some of these things that either there hasn't been a lot of funding invested, whether it be private or federal research funding on these particular issues, but also it might garner the ability for some breakthroughs.
Yeah, and obviously I totally agree 100%. I think, obviously the U.S. healthcare system must get better faster, right? The pandemic really exposed a system that was fragmented, inefficient, relying on legacy systems, and was very difficult to change in a time where it needed to change quickly. And I think as agencies and organizations get into developing these applications, it really has to be around the human-centered design approach, right? Trying to solve the problem and technique that puts the people, real people, at the center of the development process, while enabling them to really create products and services that resonate around the tailor to our audience. And that audience is really getting back into the research, which you just spoke about. I think we have to leverage these tools and leverage the emerging technologies that are really out there for, improving the cures and diseases and scalability, and really looking at equity, looking at cost, looking at data privacy, and really looking at AI within healthcare, and then promoting the best decision based upon that data that we see within our environment. And that will definitely help protect and help improve the public health environment.
I want to add something really quickly because Dion brought up the data privacy, and I want to just, Councilmember Henderson raised a really good point that I should have been more clear about. We're not sharing individual risk data with employers. We're doing it at an aggregate level. So it's partnering and thinking about how you could address things. I definitely, as much as I love where I work, would not want my company to know anything about my healthcare. So yeah, I just wanted to make that clarity because it's important that we make the distinction about like what types of data are being shared where and what's appropriate. And I think that's going to be really, really important to the conversation going forward. So just wanted to make that clear.
I think that's a really great point that I'll jump onto to say that's true. And we also need to be thinking about how the different parts of our healthcare system come together to realize the vision of what Councilmember Henderson brought up, right? Because right now we have payer data, provider data, social determinant data, right? We have patient-generated data and information. And I would really encourage us to think about how bringing all of that together in an aggregated but de-identified way can really power what Councilmember Henderson was talking about, right? To understand and let machine learning and artificial intelligence give us new patterns that can help us predict disease, predict bad outcomes in healthcare delivery. And we still have too many silos of data that we need to break down going forward.
Dr. Arnaud, any predictions?
Well, I do think it's all we've covered a lot. I think the issues pertaining to the abuse of some of the data, I think, is a concern, and it's actually a current barrier to people seeking care, the ones that need it the most, because of the biases that are built into the system. And so I think we should prioritize taking care of those issues, because it becomes yet another barrier to the way people seek care, or it becomes a barrier to care. So for me, that's one of the things that, as I'm focused in a very laser-like way on inequity and how we solve for that. The other thing that I don't think we think enough about, and this is coming home to me more and more, Lauren mentioned, we easily like to connect food insecurity and things that feel like they have a medical biological connection to our health, and we don't sufficiently take into account a job, for example. And this doesn't mean a job in relation to health insurance, which is where we talked about it before, but more of a job is the number one thing, and income that is the driver. And what are the things that we have to do as a community to ensure that people are not continuously put into a position where they can't afford, no matter, even because to me, my sense is that even as I'm working on health literacy, I am aware that for the most part, people know what would make them healthier. They just can't afford it on a regular basis. So one of the things that I usually talk about in my Health Equity 101 is the choices we make are shaped by the choices we have. And so my sense is that we can't silo health and health care outside of the greater economy and all the other things that are happening there that are negatively impacting people's ability to earn a livable wage and live in a quality environment on an ongoing basis, as opposed to housing insecurity and all the other things. So when I talked, for example, at the beginning about, yes, there may be 25% of folks in the district who don't have high-speed internet, we know that in some neighborhoods, up to over 50%, well past 50% of residents don't have that access. And so it is those systemic inequities that we really, really must address. And to the extent that we can use technology to address those issues, and that the healthcare sector, which is part of where we generate the most income and we spend the most money in this country in many respects, how can we connect those dots beyond the health care part of the work to kind of just quality of life and quality of living and income? That to me is where, if we could use big data to solve some of those problems, that to me would be a win-win across the board.
Thank you, Dr. All right, just want to remind the audience that if you have any questions, please put them in the chat. Do you have any additional questions?
While we're waiting on questions, Dr. Arnaud's comments led me to want to talk a little bit about some of what I keep alluding to with AI, which is, it was mentioned a little bit earlier, the data at Northwestern, but it worries me about how we train artificial intelligence algorithms on inherently biased data. And I worry with so many digital health startups with the AI in their name, right? How many are truly being good stewards of what Dr. Arnaud was talking about, and making sure, and what Lauren spoke about earlier, making sure that social determinants and doing subpopulation analysis of algorithm outcomes in the area under the curve for subpopulations is being done rigorously, so that as we apply these things in healthcare, we don't further amplify bias and outcomes that are unequal across populations. So really, really important part of the future. And there's some wonderful work going on at MIT and in other places where they're trying to create frameworks for making sure AI is just to all patients.
Such an important point. Thank you. Well, if no additional questions, I want to thank this incredible panel for your time today and your participation, fantastic insights and ideas. And I'll turn it back over to Angela.
Well, thank you so much. What a great conversation. And I believe that this kind of conversation starts initiatives or, moves the needle somehow. So I hope, Councilmember Henderson, that your wishes come true and we'll continue the conversation. Well, and thank you all for joining us this evening. I hope you found this conversation engaging and educational as I did. We could not put events like these together without the support of our sponsors. And I want to thank our event sponsor, CareFirst. Thank you so much. Platinum sponsors, DC Health Link, and gold sponsor, MedStar Health and AmeriHealth for your ongoing support and participation. I wish you all a great evening and a great weekend. And again, thank you so much for your contributions. And I look forward to continue to working with all of you in different capacities. I think there's a question, so if you don't mind, if we can answer the question, but I want to, you're such a great panel. It says, thank you all for the dialogue. Appreciate the systems-based approach comments. Health equity is so much bigger than the healthcare system. That is true. I don't know if anybody wants to comment something on top of that comment.
You're here.
Here, indeed. Here.
Yeah,
I 100% concur.
Great. Well, thank you all very much. I really appreciate your support. I know I work on one-on-one with many of you and, being part of your committee, Dr. Arno at DC Health and Councilmember Henderson, that we work together, but, just count on the DC Chamber for anything we can do to support health and wellness of our DC residents. Have a great evening.
Thank you all.
Thank you. Have a
Take
great
care.
evening, everyone.
Bye.